Today on Second Opinion, GLP-1 medications are everywhere, touted as game changers for weight loss, but what are they really doing inside of your body? We break down how they work, the real side effects, and the financial costs many patients are facing. Plus, one woman shares her personal journey navigating the promises and the pressures. Then, multiple sclerosis and the African American community. Why are we seeing disparities and what you should know about early symptoms and advocacy? And your body is always speaking, but are you listening? We explore the power of mobility, stretching, movement, and why tuning into your body's wisdom may be the key to long-term health. This is Second Opinion with Dr. Ebony Jade Hilton. Let's get into it. Now, up first, we're tackling the popular new trend of weight loss drugs using GLP-1s. Now, GLP-1 stands for glucagon-like peptide 1. It's a hormone produced in the gut that regulates blood sugar, slows digestion, and signals fullness to the brain. It was originally approved in 2017 by the FDA for adults with type 2 diabetes. However, the weekly injection was not originally intended for a weight loss drug. That was what some called this welcomed side effect that they saw. And that side effect has now turned into this drug being a hot commodity. Now, how hot? Well, how about these stats? Roughly 1 in every 8 U.S. adults are now using GLP-1 medication for weight loss and diabetes or other conditions. In fact, between 2019 to 2024, there has been a 600% increase in the number of prescriptions for GLP-1 receptor agonists used for weight loss alone. So joining us now to shed light on this GLP-1 movement is Dr. Michael Knight. He's the chairperson of the National Medical Association's Board of Trustees. Welcome, Dr. Knight.
Thank you. Thanks for having me.
Yeah. So tell us again, how were GLP-1s? What were they originally intended for? And how have we now transitioned to this being a product of celebrities, really?
Yeah, thanks for that question. So, spending a lot of time in this space, I'm an obesity medicine specialist. And one of the things we know is that GLP-1 is a natural hormone. So everyone has this hormone. And as we learned more about it, we found that it was pretty effective in helping our bodies control our blood sugar. And that is why it was first introduced to the healthcare space as a treatment for diabetes. But to your earlier point, we also started to understand that as a hormone, it played a role in how we manage our weight. So if you think about, for example, patients that have weight loss surgery, we found that the natural GLP-1 levels in someone who has weight loss surgery skyrocket. So we said, well, maybe if we increase the way that our body sees GLP-1, right? So if you give a GLP-1 receptor agonist, meaning that we cause the receptor to feel like there's a lot of GLP-1 in the body, are we going to see weight loss? And that's exactly what we saw. So what we now see is very highly effective medications that are able to replicate the natural GLP-1 in our bodies to not only control sugar for patients with diabetes, but also to decrease weight for those living with obesity. And one of the reasons we've seen this demand is, as you know, over 40% of American adults are living with obesity, a condition that is linked to things like cardiovascular disease, diabetes, high blood pressure, and almost 180 other conditions. So there's been a pent-up demand for effective treatments for this condition, and that's what we're seeing.
Now, in this, build up for it being a weight loss agent, of which it has shown tremendous kind of impact, what does that mean for the type 2 diabetes community, though? Are we now seeing a struggle of them being able to get the medications they need to literally survive?
No, not at this time. We have had, because of the demand and because we're in a society where demand leads to investment, the number of GLP-1 treatments that we have on the market is more than enough, not only for our patients with diabetes that effectively have those treatments, but also for obesity. Now, when it first came out, the demand was so high that everyone was struggling to find this medication. But today, we have not in my practice or heard in our field of patients with diabetes struggling to get access.
And do you see this as a fad? We've had other weight loss agents that have come on the market, Fen and other pills, right? Mm-hmm. That were promised to be this weight loss miracle. And now we've seen how they've kind of left the market due to kind of risks that were associated with those. Mm-hmm. Do you think this is more of a permanent fixture in weight management and something that people should look into because of its safety profile?
I think we're going to see it for a very long time. Obviously, things evolve over time. And what we're seeing now is not only GLP-1, but GLP-1 plus GIP. And some new treatments are coming now that have 3 different receptors that are targeted. So I think we're going to continue to see that evolution. But the difference between these treatments and some of the fad movements that you mentioned in the past is that the level, the threshold for approval is so much higher because we have had agents in the past that have caused things like heart conditions and things that we really, really don't want to see. So it passed the test of time, if you will. The safety profile, of course, we know that there are some possible side effects like nausea, GI upset that can be worse for some patients than others, but not the severe mortality or cardiovascular risk. And actually, we see cardiovascular benefit. And so that's when I think that we're going to see longevity here. And again, not just for the obesity, but also we see improvement in cardiovascular. We see improvement in sleep apnea, a variety of other conditions that we're going to continue to see benefit here.
And if our audience is listening and they say, hey, I have sleep apnea, hey, I have cardiovascular disease, are they a great candidate for this agent? What deems them a great candidate for GLP-1?
So first of all, I want to make sure that we understand this is not a cosmetic drug. And I think that as it has become so popular and celebrities, etc., it's like, oh, I just need to lose 5 pounds to get into my swimsuit. And so I'm going to use this medication. And so it can come across as something that is very commercial, but it's actually an FDA approved medication. And there are certain patients that is indicated for. So it's really not for the person who, is normal weight and just wants to lose a couple of pounds. This is really for people who are living with obesity as a chronic condition that's affecting many other parts of their life. And that is who we see the benefit here for. And we will hopefully continue to see longevity and an outcome improvement for it. And so if you are not only living with obesity, but also other conditions like diabetes, cardiovascular disease, if you've had a heart attack or stroke in the past, or if you have sleep apnea, this may be a great option for you to not only address one issue, but address many issues, because obesity is the root cause to so many conditions. And instead of trying to play whack-a-mole, right, with everything, let's get to the root of the problem. And that's exactly what we're doing with GLP-1s today.
Now, if the audience member says, hey, if I take the GLP-1s and I do that alone, will I lose the weight, or do I need to also go to the gym? Do I need to also change my diet? Or is this truly a miracle drug?
So two things can be right at the same time, right? I still do think it's a miracle drug, but you have to understand, to get the most benefit, it has to be tied to those foundational pieces that we know when it comes to weight management. That is physical activity. That is nutritional changes. And so a lot of times people say, you know what, I don't want to cheat. I want to do it the right way. It's not one or the other. My patients that I have on these treatments are on lower calorie diets, on a high protein diets. They're avoiding those highly processed sugar sweetened beverages, but they're also in the gym. They're also active. One of the things that you have to keep in mind with GLP-1s is that you can have muscle mass loss if you're not exercising. And so my patients, I tell them every day, hey, you're losing weight, but you're not just losing fat. You're going to lose muscle if you don't exercise. So it is a comprehensive approach to obesity treatment. GLP-1 is one piece of it, but it is a part of a comprehensive approach. And so if you're talking to a healthcare provider and all they're doing is writing you a script and giving you no other recommendations, you really need to consider, am I getting comprehensive care? It's not a shortcut. It is an additive tool that we add to a comprehensive approach to treating obesity.
And when you say you may lose muscle mass, if someone is now on GLP-1s and they say, hey, yeah, I've noticed that my muscles I'm looking a little bit skinnier, right? And that's the point of helping to remove the fat, but I feel like I'm losing my muscle. What health implications are associated with loss of muscle mass?
So many implications. So obviously you can think about functional ability. So weakness, our losing ability to even walk in the most severe cases. But again, this is not just to GLP-1. Anytime you lose weight, you don't just lose fat. You always will lose some muscle mass. And so even when we think about patients who've had weight loss surgery, where we see significant weight loss, if they're not eating or drinking their protein, if they're not exercising, doing resistance exercise, they can lose significant muscle mass that can lead to even disability. And so with GLP-1s, even though it's not that severe, it's really important to stay physically physically active. And that resistance exercise where your muscles are getting toned is so important to reduce the amount of muscle mass that is lost.
And it's probably one of these things where you feel better, so you have more energy to actually do it, right?
Exactly.
Now, doctors are saying that you're supposed to wean off of this, right? Are they supposed to wean off? Is this a you start it and this is what you will use for the rest of your life? How does that kind of work?
Yeah, I think to answer that question is understanding that obesity is a chronic condition. Mm-hmm. It's not a one and done. It's not I went and got my gallbladder out and now I'm fine. It's just like diabetes. It's just like high blood pressure, right? If I give you a high blood pressure medication, your blood pressure is controlled and you're like, great, now I don't have to take the pill. And then tomorrow your blood pressure's up. So it is a chronic condition because we understand that people who are living with obesity, majority of people living with obesity have had changes in the way that their body manages weight in a way that is abnormal. And so what the GLP-1 or any medication that's treating obesity is doing is helping to normalize that and bringing you back to a level. But that is only as long as that medication is acting. So for most patients, this is a chronic treatment. Does that mean 100%? No. There are some people who wean off. There's some people who take holidays, if you will. But it's important to have that comprehensive discussion with your healthcare provider to understand what makes sense for you. We are also seeing that some individuals may be on an injectable GLP-1 and they get to their goal weight and maybe they shift. Either they're shifting a dose, they may be shifting to an oral medication. There's a lot of different ways to do it. But I have to just understand that it's not just pushing back from the table. Right. There is a pathophysiology, that means abnormal process that is happening that has caused this excess weight. And so if you stop treating it, then it is expected that it can come back.
Now, we've seen several celebrities endorsing this agent, right? Oprah, Serena Williams, I think Charles Barkley, I think I also saw him endorsing GLP-1s. But recently, comedian Monique said that GLP-1s, they take away your willpower, right? To lose the weight, it strips you of your willpower. Are you seeing that with your patients in the clinic, or is that just a one-off kind of description of what kind of she has experienced in herself?
Yeah, I think everyone is different. And it's important that the obesity journey is a personal journey. I would say the majority of my patients would not share that viewpoint. They don't feel like it's taken away their willpower. They actually feel like it's giving them tools and giving them confidence to take control of their health in ways that they never have been able to before. Mm-hmm. I tell you about patients who have told me they've never felt full in their whole life. And they're like, I finally feel like I don't have to eat everything on this plate. I actually am not thinking about food. I've lived my entire life thinking about my next meal constantly and thought that was normal. And many of us who don't live with obesity, we don't know that experience. And so we say, well, why don't you just stop eating? Or why don't you just do what I'm doing? But we don't understand that the way that we're even thinking is impacted by the pathophysiology that happens. And so I will say, I don't think it takes away your willpower. I think for the right patient, it gives you the tool to take that next step. And so if it's not for you, then it's not for you. But I can tell you the number of people that I've seen their lives transformed. I'm telling you, coming in with a new pep in their step, a new wardrobe, a new glow on their skin because they finally feel like they have control and that they're moving towards their best health potential, which is what we're focused on. If you can fit into that dress too, wonderful. Right. But I'm most concerned about, are you healthier? Are you going to live the best life? Are you going to be there for your grandchildren and your great-grands? Mm-hmm. And if I can say that, then I am very satisfied.
Right. And I've seen it clinically in the operating room. I've seen plenty of patients come in, and to see the studies showing longevity of life, cardiovascular improvement, these things matter. Cancer reduction, I mean, the limits on the overall improvement of health, I think, are yet to even be seen. Correct. And you spoke about the personal impact. So I want to bring in our next guest, Dr. Linda Henderson-Smith, into the discussion. She's a psychologist who's also been using GLP-1s for about 2 years now. Welcome, Dr. Henderson-Smith.
Thank you. Hi, everyone. How are you?
Good. So what made you start using GLP-1s? Were you kind of in the know of GLP-1s based on your profession, or did you hear it on TV like most of us have?
I actually didn't even hear it on TV. I think I might have seen 1 or 2 commercials, but in actuality, my doctor brought it to me. I've had hypertension for a while and obesity, and I had done the work to change my diet. I had started exercising and going to the gym 3 to 4 times a week, but still wasn't able to really get any of the weight off. And so he made the suggestion that I try Wegovy. And at the time I was working for an insurance company and they covered it. So I was like, sure, let's try it. Anything will, like, I just need to try something because this is not working. And so I tried it and it began working relatively quickly. And so I was on it until I left the insurance company, and it went from $100 a month to $1,500 a month.
Wow.
So that was a hard stop. But once I was able to, get work, get insurance again, I went back to the doctor and he suggested that we actually try Zepbound this time. That was still $1,300 a month. So I chose to go the route of the compound tirzepatide through, I think it's through another company. And so I've been on that for almost a year now and have continued to see better health. I can walk better. I can exercise better. I've had the ability to reduce my blood pressure medicine, right? Like, so it's really truly helping in multiple ways.
You brought up so many great points. One that really stuck out to me and is ringing in my ears is the fact that it went from $100 a month to $1,500 a month. Are we creating a two-tier system where only certain populations can actually afford to benefit from these agents that you literally are saying, this is changing my life for the better? What are you seeing, both of you?
I would certainly say that, access is a huge issue. And I brought this up even to some of the companies that are developing these things. I said, are we making disparities worse? Is it now becoming that obesity is a poor person's disease? And if you have enough resources, there's really no reason to live with obesity because we have these highly effective drugs. And that is a huge challenge. And so that is one of the reasons we continue to advocate at the National Medical Association and others about access. Not access, again, to a cosmetic drug so that I can go to the beach. Access to an FDA-approved treatment for a medical condition. We are now seeing a shift because, again, a lot of things like Medicare, for example, Medicare has a complete ban on any weight loss drugs because, again, of those fad approaches, fad treatments. And seeing that to transition to, no, we are actually going to pay for an FDA-approved medication. I mean, we wouldn't say to someone with breast cancer, we're not going to cover, we'll cover everything except your breast cancer treatment. Like, that's not health insurance. And so whether it's Medicare or Medicaid or even commercial insurance, the one benefit I will say is because of the demand and now there's competition in the market, that out-of-pocket price has gone from that $1,300 and $1,500 that you heard earlier to now $200 to even $500. Of course, that's still a lot for many people, but it is certainly better. And what we're seeing is continued improvement. And hopefully that price will continue to come down so this is accessible to anybody who is living with obesity and wants to be treated with this agent.
Yeah, because as you mentioned, 40% of the viewing population is saying, hey, this is my life story. So how can I get help? And Dr. Linda, when you mentioned that you saw immediately how it was working, can you describe what does that mean? Was it your relationship with hunger, cravings, your emotional eating, or was it something physically that you felt like was different?
So I think the interesting thing with me is I was never an overeater. Right. So I was always one that would barely eat, meaning my body was going into starvation mode. What I started to see was that it was actually telling me you're hungry and you're full. Right. Like, so it was, hey, it's like you're hungry. You need to eat. You need to eat. Like, it was telling me that I needed to eat, but it was also telling me when I was full. And so I was able to basically retrained through the GLP-1, retrain my body from kind of staying in this starvation space of I'm just not going to eat and I'm going to hold on to everything, to eating on a regular basis, so that I started to feel better. I started to sleep better. I started to be able to exercise. I started to be able to just have energy throughout the day. I no longer drink caffeine. I really only drink water, right? Like, I really started to feel the positive impacts within about 2 months.
And can you explain to people the starvation? You hear people say all the time, hey, I don't overeat. I barely eat throughout the day. Can you explain the mechanism by which the body then therefore says, hey, we are in a famine. I need to retain. What does that mean?
So, well, at least the way that my doctor explained it to me, right, was very simple. If you don't feed yourself, your body, similar to people in the past who were not able to eat, right, goes into starvation mode. It goes into, it's basically your body's survival mode of, I've got to store the fat to get through these long periods of time where we're not able to eat. And so because I was working all the time and I had kids and right, like all the things, I just went into this. I don't need to eat. I would eat once a day, maybe, right? Because I would forget that I should eat. I'd be in meetings or whatever, and I just would not eat. And that was causing more problems for me than I knew until my doctor explained that.
Yeah. Yeah, I think that's a very big point for people to kind of understand, especially if they're struggling with weight and they're thinking, why am I if I don't eat? You know, one thing as a psychologist, I'm curious, how do you cope with, or do you think there's a stigma around people saying, hey, if you're on GLP-1s, that's cheating and it's a lack of willpower? How do you combat that stigma and make sure that the general public says, hey, even if you're thinking that, it's not true? And these are agents that can actually help you to improve your mental and your physical health. How do you speak towards that?
So I tend to speak towards it similar to what Dr. Knight said, right? It's if somebody had cancer, you wouldn't tell them don't take chemo, right? Like if someone has diabetes, you wouldn't tell them not to take their insulin. Obesity is a disease. And so if obesity is a disease, there's medications that can help with that. This is what that is. This is not a, one-stop shop, like, oh, I'm just going to just lose all this weight, right? It's not cosmetic surgery. This is a medicine to help your body reacclimate to what it needs to be and get you to eat and in the way that you're supposed to and feed yourself in the way that you're supposed to. So I always say, if you are telling me that I shouldn't take a GLP-1, you might as well tell someone who has cancer not to go through chemo. It is the same exact thing.
Right.
When you put it in that kind of sense, people tend to think about it a little different and tend to back down pretty quickly. But I also just think we've got to work towards not stigmatizing people trying to be healthy in whatever ways they can. Right? Like as humans, we should want to support fellow humans in being healthy and living long, healthy lives. And so if some people choose to use GLP-1s, some people choose to have surgery, some people choose to just do diet alone, some people do diet and exercise, right? Like whatever people's choices are, number one, they're theirs. But number two, as humans, we should just support other humans in their health journeys.
Exactly, because it's really not your business. You want to tell people.
At all.
And I'm curious, Dr. Michael Knight, when we have patients on these, is there any concern about them being psychologically dependent on these medications? Like a fear that if I stop this, I'll regain? And how should, clinicians, how are you addressing that in the clinic?
Yeah, one of the things that is important here is when we talk about holistic comprehensive care, it's not just physical care, right? It's also thinking about mental health. Mental health and obesity overlap in many, many patients. Many patients living with obesity are also having mental health challenges, and a lot of times it's interconnected. And so as I interface with a new patient, I'm trying to understand how has obesity affected them not only physically, but also mentally? And how is their weight loss or improvement journey going to affect? There are some individuals who, have anxiety. They've lost this weight and they're terribly afraid of regaining it. And so that can lead to abnormal behaviors. Some people use food as a comforter, right? And now that it's not food, now it's alcohol, now it's something else. And so we have to understand that is one of the reasons it's important to go to a healthcare provider who's going to treat you comprehensively, who's going to check in with you, not only just check what's on the scale, but how are you doing mentally? How are your relationships? How are things at work? How are you navigating a world in a way that you didn't? I mean, think about if you have lost 100 pounds, that is a very different world that you are navigating now, right? How you travel, how you deal with other people, how other people perceive you, how your friends and family perceive you. I often have patients who are like, yeah, my family's telling me I'm losing too much weight. And I'm like, I wonder why. Is it that there's some jealousy sometimes? Is it that people expect that, oh, you're the larger person and that's your role? And now, they may feel intimidated by you. That changes relationships. There are people that unfortunately move out of relationships as a result of that. Sometimes because they know their worth now, and they were actually not in a great situation, or sometimes because their partner now is starting to treat them differently. And those are all things that proactively have to be addressed, and that's why mental health and our environment is so much a part of treating obesity, not only on the medical side but in the holistic side.
Dr. Henderson Smith, I'm curious, did you encounter any of those, changes in relationships? Were there, and outside of, I guess, even relationships, were there any side effects that you personally experienced with using and are currently experiencing with using of these agents?
So I haven't had any side effects, if I'm honest. I have rheumatoid arthritis and Sjogren's, as well as lupus. And so it actually has helped in those areas. I've actually had positive side effects, not negative ones. So for me, I think I might be a little different than others. So like I'm able to walk better. My blood pressure is lower. I'm not having as many flare-ups and things of that nature. And that's what I've noticed since I've started the GLP-1. And in terms of relationships, no, I think, so when I was younger, I was smaller and then I got larger after I had kids. And so for those friends of mine and family members of mine, they knew about that struggle for me and knew what the issue was. So there was no kind of pushback in that space. Let me say this, that I'm aware of. People, they haven't brought it to me.
Right. And they know not to. And here's a question. When you stopped briefly the use of the agent, when you changed jobs, did you see a fluctuation in your weight?
I did see some of it come back, but not all of it. So the good thing was I saw maybe 50% of it come back, right? But then it was 9 months later, I started again. And so I was able to then continue with the loss part, but which of course wasn't necessarily very comfortable for me but at the same time, I knew that was a side effect of me stopping the medication. So, I continued to exercise. I continued to eat right. I continued to drink water, right? Like I continued to do all of those things to make sure that I didn't go all the way back and go past that, right? But I did make sure that I did see that, yes.
Dr. Knight, Dr. Henderson Smith just mentioned that her symptoms of rheumatoid arthritis and other autoimmune conditions actually improved with this agent. Are you seeing the same thing in your clinic with some of your patients where they're saying, hey, this had nothing to do with obesity directly, but I'm seeing that this, and this that I think are totally random are actually starting to clear its way, whether that's eczema or other, autoimmune-like illnesses. Are you seeing that or no?
Yeah, we are seeing that. What we are seeing also are signals that GLP-1s are also decreasing inflammation. We know inflammation is a part of autoimmune conditions. And so I've seen many of my patients who have autoimmune conditions, whether it's lupus or rheumatoid arthritis, have decreases in their number of flare-ups or their severity of a flare-up. And so while it's not approved as a treatment for those conditions, we're certainly seeing an improvement. And so that's why I think as we move on into the future, we're going to see a lot more applications for this class of drugs, because we're still learning how it improves and impacts the body. But we are seeing a positive impact on decreasing inflammation in the body.
Well, Drs. Knight and Henderson Smith, thank you both for being here. This has truly been one of those segments I've been looking forward to, because there is so much information out there and it's hard to know what to kind of lean into and trust. So where can people find you? If they want more information about, am I a candidate for this? Where can I actually go? Do I have to go to my doctor? Do I use the HERS app, and get this agent through Serena Williams app? Where should they go to get more information for you? Dr. Knight.
Yeah, so one of the first places is if you have a primary care provider, really talking to them about opportunities either for them to treat you, or if they don't treat obesity, to connect you to someone. The American Board of Obesity Medicine is a great website that has a list of providers or physicians who are board certified in obesity medicine. I'm board certified in obesity medicine. That's a great way to know this is someone who's trained to do this. And then, of course, we're seeing this across the board. What I think is important is wherever you get medications, please be connected with a healthcare provider who can treat you comprehensively. I know sometimes it feels like I can just fill out a form and get it mailed to my house, but you also need someone who's seeing you holistically, who knows what other medical conditions you have and is really going to tailor your treatment plan.
Well, I thank you both, and we will be in touch with, I know this is going to be a part 2 segment because, again, there's so much research coming out from GLP-1s that we have to do a deep dive on how this literally can shift the disparities we're seeing in the African-American community just in large. So thank you both.
Thank you.
Thank you for having me.
And still to come, we're taking a deep dive into multiple sclerosis and how it impacts the African-American community.
I'm Brittany Noble, Midwest-born, HBCU educated with experience in newsrooms across the country. I've teamed up with Roland Martin to bring to you The Breakdown. This isn't just news. It's our stories, our voice, our community. Join me for The Breakdown, Monday through Friday at midday, only on the Black Star Network.
The American Autoimmune Related Disease Association estimates that 1 in every 5 Americans is living with an autoimmune disorder. Johns Hopkins Medicine defines an autoimmune disorder as when the body's natural defense system can't tell the difference between your own cells and a foreign cell, causing the body to mistakenly attack normal cells and literally attack yourself. Examples of these disorders are type 1 diabetes, lupus, and multiple sclerosis. And today we'll talk about MS. Over 1 million Americans are living with this condition, and it's estimated that as high as 10,000 new cases will be diagnosed each year. So joining me now is Dr. Mitzi Williams, a multiple sclerosis expert and diversity and inclusion thought leader. Welcome, Dr. Williams.
Thank you so much. I'm so excited to be here and talk with you about this topic.
Yeah, and talk to what is exactly multiple sclerosis, and do we know what potentially causes it?
Yeah, so it's an excellent question that I get very often. So multiple sclerosis is an autoimmune disease, which you already described, meaning the immune system, the part of the body that normally attacks viruses and bacteria, gets confused and attacks a good part of the body. As it relates to multiple sclerosis, the part of the body that's attacked is the myelin, or the coating of the nerves in the central nervous system. The central nervous system includes the nerves to the eye, the brain, and the spinal cord. And so when this myelin, or coating of the nerves, is attacked, it results in damage that can cause different symptoms. And it really depends on where the attack occurs and the extent of the damage. So people can have symptoms like numbness and tingling. They may have visual loss. They may have weakness on one side, symptoms that are very similar to stroke, but it often occurs in younger people in the age group of 20 to 40. So these are usually very healthy people who all of a sudden, have some type of weakness. And so it can be misdiagnosed if someone is not looking for it specifically, because the symptoms may come on and then go away. In terms of what causes MS, there are a lot of different factors that we know increase the risk. So we know that genetics plays a part, but there are over 200 different genes that are related to increased risk, and they're not necessarily bad genes. They're good genes in a bad combination. We also know that the further away you live from the equator, the higher the risk of MS. We see very little MS in tropical areas, and we see the most MS in Eastern Europe. And then we also know that other factors such as viruses and infections, such as Epstein-Barr virus, can be a risk factor. So some combination of all of those things that will make one person have MS and the other person not.
And is there any rhyme or reason why location actually matters? if you're in East. Yeah, go ahead.
Yeah, so that's a very common question as well. We think it might be related to vitamin D levels. So we know that low vitamin D is a risk factor for MS. However, everyone with low vitamin D, which is virtually every patient that I meet, whether they have MS or not, is not the whole story. So certainly low vitamin D, but I think also in particular areas like, for instance, the continent of Africa, we don't know a lot about MS because of resources and things like that. So there may be more MS in those tropical areas than we have previously known, just because we don't have the resources or research in those areas to better understand.
Now, you mentioned that symptoms kind of come and go and that they can be a weakness. Can you describe what it feels like? So someone that's in their 20s or 30s, that's really young, right?
Yeah, absolutely.
If they're experiencing something and they say, hey, well, maybe I was just tired this last week because I feel better now. What should be a red flag to say, no, you may need to go get this checked?
Yeah, so I think that if someone has new neurologic symptoms, it never hurts to go get checked, right? We would rather say, okay, your iron is low than you actually have a neurologic disease that needs to be further evaluated. Mm-hmm. But the typical symptoms will be something like a person who's very active will say, I developed numbness in my foot, and over several days, it spread up my leg or up my whole side. It may have lasted for a couple of weeks. I went to the doctor. They said it was a pinched nerve and it went away. So I didn't follow up. Mm-hmm. And so that's a very typical history of someone who's had their first episode of MS, but for some reason was lost to follow up or was not diagnosed. And then maybe 5 or 10 years later, they may have another symptom, or they could have another one in 6 months. So it's just very variable.
And how is it diagnosed? If they go in and say, okay, yes, I have this weakness. I don't think I'm having a stroke. Please tell me I'm not having a stroke. How are we diagnosing MS today? And is there a reason why Black patients in particular are often misdiagnosed or diagnosed at later stages?
Absolutely. So we diagnose MS by looking at the clinical history. So a history and physical, right? The mainstay of any type of medical encounter. But the key is MRIs of at least the brain and the cervical spine. And so oftentimes what happens is someone will have leg weakness and they may go to the doctor and they get a lumbar MRI, which is the lower part of the spine. And that may look okay, or maybe they have a little arthritis and no one thinks to look further up because the symptoms can be coming from further up in the central nervous system. So that key is getting an MRI of the brain and particularly of the cervical spine, because we see lesions in the brain most commonly with MS. But if someone doesn't have a suspicion to look there, then it definitely could be missed. Yeah, absolutely.
And let's say we do see lesions. What's the treatment at that point? You say that the symptoms come and go. So do we just say, okay, my symptoms got better, now I'm safe? Is there?
No. So MS is a progressive disease. So one of the most important things that we try to get out to the community in educating people is to recognize that we need to diagnose as early as possible to prevent disability, right? So one of the reasons that Black people are underdiagnosed is because, number one, when we go to medical school, we learn about MS as a young white woman's disease, right? So we have this picture in our mind that doesn't fit the person that we may see in our community. I live in Atlanta. So the vast majority of my MS patients are Black and African American. Mm-hmm. So if a doctor doesn't have that suspicion, they're not going to go looking. And so when we think about treatment, treatment is really preventative. So what we want to do is prevent future damage from occurring, but we don't yet have treatments that fix what's already broken. So the least amount of disability you start with, our ideal is if we catch somebody who had that first episode and they're back to normal. We want you when you're normal because our goal is to keep you that way. If we wait until something else happens to you, let's say you lose feeling in a leg or you have weakness, your ability to recover is something we can't predict. So you may get 100% better, you may get 50% or 25% better. So we're really taking a risk on waiting for something else to happen to you to then try to intervene and prevent further damage. So we want to catch people as early as possible to prevent disability over the long term.
And are there any triggers, right? Are patients telling you, hey, I'm coming in because I'm having new symptoms. And have there been any research that says these are some of the things that kind of trigger a NETS flare?
So very common question. Now we have in neurology, we often have a thing and then we have a pseudo thing. So we have a flare, right? Or an exacerbation, which we think is due to new inflammation in the central nervous system. So you got a new lesion or one of your old lesions is acting up with new inflammation. But we also have what we call pseudo relapses or pseudo exacerbations. And those are things that occur, let's say, if you're out in the Georgia heat, we know that heat typically makes central nervous system or neurologic things worse. So whether heat is from heat exposure, whether heat is from an infection or fever, it can temporarily make those old things come back out. And so that will be more of a pseudo relapse, or if you get exhausted and go on the family vacation and then you're down for 3 or 4 days. So we do know the triggers for pseudo exacerbations, but unfortunately for a true exacerbation, there are not any known triggers. They often happen out of the blue when people are just minding their business, doing all the things.
That is a scary thing and unfortunate. You know, we know that Black people are often experiencing a more aggressive disease course when it comes to MS, and including faster progression to disability. Why exactly do you think that is? Is there something genetically related to us, or?
Yeah, so that is my life's work, right? Is trying to better understand MS in underrepresented populations. So there are a couple of things. One, as with just about any other disease, we are vastly underrepresented in clinical trials. So the vast majority of our clinical trials are done in Eastern Europe. So when we're talking about the medications and our opportunity to really see what we call just the course of disease in our clinical trials, we are not included. So we are usually anywhere between 2 to 15%, but most of the time it's more like the 1 and 2%. Okay, so less than 5% in all of our major clinical trials. So that is one issue. The other issue is, again, people are going in with symptoms. They are being told they have psychiatric issues, or if people have mental health issues, they may be pointed in a different direction. And so the doctor has to have that suspicion, and somebody has to put the pieces together. So I'll never forget a patient I had with severe schizophrenia that I was seeing at our teaching hospital, Grady Memorial Hospital. And the woman, when she came in to see me, was referred, by a colleague of mine, was giving me a classic history of MS. And she's like, sometimes I drag my leg and it'll happen for a month and I might be in a wheelchair or on a cane and then I'm walking fine. And that has nothing to do with schizophrenia, right? But because of that, everyone was just kind of blowing her off. And unfortunately, she had really severe disease before we could intervene. And so I think that is not an uncommon occurrence for people in our community. Also in our community, we're not really familiar with MS, right? We know about diabetes. We know about other things, hypertension, things that mom and grandmom have. But MS is not something that we talk about as often. So there is also not an awareness. So if someone has a symptom that goes away, they're like, okay, I was fine. It was a pinched nerve or I slept wrong. So I think, the bottom line is if we're having neurologic symptoms, we need to get them checked out. If there is an MS specialist in your area, go see somebody, right? I get lots of folks that see me to rule out a diagnosis, and there's nothing wrong with that.
And speaking of grandparents, is it a family history linked to it? If you have an aunt or an uncle who has MS, does it make you more likely to have MS as well, or no?
Yeah, so the risk is increased if you have a first degree relative with multiple sclerosis. However, if you look at twin studies, right, which they have monozygotic twins have the exact same DNA. If one develops MS, the other one only has about a 25% chance of developing it. So it's high compared to the general population, but it's not anywhere close to even 50%. So those other environmental factors, do play a role. Now, I do have some families where multiple people have MS, but the heredity is usually sporadic. So it'll be like, I have a cousin who has MS. Her mom has lupus, right? And then her aunt has rheumatoid arthritis. So we more commonly see autoimmune diseases run in a family than we actually see MS run in a family. So it's not impossible, but it's not common. And then often it will be very sporadic, a second cousin, a great aunt, something like that, but not as often brother, sister, or a parent child.
I have monozygotic twins. And so when you were mentioning that, it made me think about pregnancy. And it made me think about, women tend to have more autoimmune diseases than men, right? So if you are pregnant and you have MS, Are treatment options still available for you? How does that work and or interfere with the developing fetus?
Yeah, so we've learned a lot about pregnancy, and this makes me really excited because when I started practicing 20 years ago, we used to just take you off your medicine and hope for the best. Okay, so now we actually have guidelines due to many of my amazing colleagues that have been collecting breast milk over decades and, looking at these things in extreme detail. So we do have guidance. Now, the good news is most people with multiple sclerosis actually go into remission during pregnancy. So they do really well because you have to suppress your immune system to a certain extent to grow a whole human being. Mm-hmm. So most people do really well during pregnancy. Where we get concerned is right after they have the baby. So a couple of months postpartum is where we start to see kind of this reactivation of their multiple sclerosis. And so we want to make sure that we are having a plan to treat people. What we now know is that there are several medications. There's at least one in high efficacy therapy we can use through pregnancy up to week 34. And we usually start it a couple weeks after. And we also have guidelines for some of our other therapies where we can give the therapy. The therapy lasts for 6 months. We tell them to use contraception for a couple of months, and then we can give them, some months to try to conceive. And then we can start that as early as 2 weeks postpartum, and it's fairly safe to breastfeed. So these are great advancements that we've had and really exciting news for our pregnant patients because we ultimately want them to be able to take care of the babies once they have them. So we do have a lot more information now than we did even 5 years ago.
That is absolutely fantastic news. And the question, how is the treatment overall? The quality of life that people have with MS 10, 15, 20 years ago could be pretty bleak, right?
Yeah.
What are we seeing now?
Yeah. So this is absolutely amazing. So one of the reasons I became a neurologist is because I knew that, our treatments and advancements would change over time. Mm-hmm. So MS is a disease. If you think about the 50,000 foot view, a disease that's been around since the 1800s. We've known about MS since 1868. There were no FDA approved treatments for MS until 1993.
Wow.
And from 1993 to now, we have 25 plus treatments. So my waiting room looks completely different now than it did 20 years ago. I have a lot less people in wheelchairs. I have people that are, raising their kids, having all the babies, getting their PhDs, doctoring, lawyering, doing all the things. They have some issues, right? And some constraints. But there was a time where we automatically were looking to take people out of work after 10 years of disease. So the treatments have absolutely advanced in terms of allowing people to live almost a normal life. And I've got some patients that are in better shape than me. They work out more than me. I mean, they're doing great. So that is our goal. That's why we want to catch it early, because we want to keep you as normal as possible.
Well, thank you, Dr. Williams, for this discussion. I know it's going to help to save lives because people are going to now trust their bodies when they're seeing that something is just not right and
Absolutely.
Go and actually seek care. So can you tell people if they don't have a primary care doctor, if right now they have some questions though, because I felt a little bit weak last week, can they get in touch with you? Is there a platform that you would kind of direct them to say, here are some answers?
Absolutely. So I actually have a podcast called Brain Chat with the Nerdy Neurologist that we're relaunching in a couple of weeks. So many of these topics I address in that. And then I'm on social media as the Nerdy Neurologist. And I often do a lot of very easy videos, early symptoms of MS. How do I know I have MS? How do we diagnose MS? So there's lots of information on my social media channels. I also encourage people to look at things like the National MS Society and the MS Association of America. They also have a lot of amazing information about diagnosis, diet, etc., and information about MS in the Black community, which is a focus of mine.
Brain Chat with a Nerdy Neurologist. We will be listening in and tuning in. Thank you so much, Dr. Williams.
Okay, thank you so much. It's been my pleasure.
Now, do you know how to turn your brain off and relax? Still to come, we share the health benefits of unwinding mentally and physically.
Hey Hey y'all, welcome to The Other Side of Change, only on the Black Star Network and hosted by myself, Bria Baker, and my good sis, Jamira Burley. We are just two millennial women tackling everything at the intersection of politics, gender, and pop culture.
And we don't just settle for commentary. This is about solution-driven dialogue to get us to the world as it could be and not just as it is.
Watch us on the Black Star Network, so tune in to The Other Side of Change.
The ability to turn off your brain and relax is not an easy task, yet it's important for your mental, emotional, and physical health. Joining me now is Danny Lynch, a yoga instructor, stretch therapist, somatic coach, and owner of Centering Essence Wellness. Welcome, Danny.
Hi, thank you so much for having me.
You know, some African Americans feel a certain way about yoga, especially those churchy. I'm from the Deep South, right? And in church. Can you explain what yoga is and what it isn't?
So I want to start with what yoga is not. Yoga is not a religion. There is no deity. There is no praying or anything to anyone. It's not a practice of faith. Yoga literally means to unite, the yoking, the integration. And the goal of it is to integrate your mind, your body, and your spirit through breath work, through physical practice, through what we call asanas, the poses, and through meditation. And so I think sometimes, because I'm a person of faith, I'm from the South, and I attend church. I'm a Christian. I attend church, and I think, and I believe in Jesus. But I think that sometimes when we're not familiar with something, we can tend to fear it. Or have a hesitancy or anxiousness about it. And so it is not any of those negative things. What it is a way to connect you with yourself.
And you're also, in addition to a yoga instructor, you're also a somatic coach. Can you explain to us what exactly is a somatic coach?
So somatic coaching, similarly to yoga in the sense that we are utilizing the body, your nervous system tools, breath work, to help someone connect with what's actually going on in their life and in their mind. So through a series of questions and prompts, as well as movement, right? I'll get to guide my clients into through a somatic coaching session in which they will identify maybe an issue that's been on their mind or a goal that they need to accomplish. And if there's some blocks there, our body holds a lot of wisdom, and we don't often listen to our body. We don't often listen to what's going on with us, what feels good, what doesn't feel good, and we just move from our mind, right? So through the somatic coaching, we're able to slow down the nervous system and really tap into, what do I want? What do I really need? What does my body say about this? And it could be something as simple as your heart beating fast when you think about something. It usually means anxiety. And a lot of times we just move past it, right? Because you got something to do. You got to go to work. You got to go here. You got to pick the kids up. But this is an opportunity for you to think about what's been on your mind and what comes up for you as we work through that. How do you feel? Do your shoulders relax? How's your breath feel? What's going on with you here? And so that's one of the beautiful things about the somatic coaching practice that I love.
Your breath, your voice is so soothing. Like you're talking, I'm like, I feel relaxed right now, and you talk about the body holding stress, right? How does trauma or chronic stress physically show up in the body, and how can somatic work help to release that?
So the body, and I'm going to tie it into somatic work as well as yoga and stretching, right? Just movement, type of mobility. So trauma will show up in our body sometimes in our shoulders. And sometimes you'll feel like if you carry stress in your shoulders, you'll have really tense shoulders, your upper back pain, right? And you don't know why. Sometimes when I'm teaching, I'll have students and I have to just constantly say, just relax your shoulders. And when I say relax your shoulders, their whole face will relax and you can see them breathe a little easier. A lot of people on this side of the world, we sit a lot for our work, or we sit in, whether it's a sedentary job or we're driving trucks or something like that, right? So we hold a lot of stress and tension in our hips. We also hold a lot of emotions in our hips, a lot of trauma. So sometimes when I'll do a hip opening workshop to help release those hip openers, to help release some of that tension, I will see people sometimes crying on their mat. You know what I mean? Because you're opening up a doorway just for some emotions to sort of free themselves. So trauma can show up different ways. Sometimes we hold it in our face and we don't even realize it. What is it? Resting bitch, whatever it is, like resting, whatever. Thank you. I was like, what is the phrase I've heard you say, right? Nothing against it. Some of my closest friends have it proudly, right? And they're fine with it. Nothing against it. But sometimes it is just stress, and it is underlying unhappiness that has you sort of gazing at the world, almost ready and tense for whatever may come next. What are you about to say to me? And you don't even realize it because you've been moving through life like that.
Right. And if you are one of those persons that says, hey, I know I carry stress. I know it is in my body. How important is stretching and relaxing? And what do you say to some of those people who say, I want to stretch and relax, but my body physically hurts. I can't do a hip opening if I wanted to. What advice do you have for them?
Yeah, no. I love teaching beginners. I love teaching people who feel like they can't do certain things, because there's always something we can do. There's different levels of yoga. There's different levels of flexibility, we'll say. There's different movements we can start with. And then through time, especially when I'm doing my stretch therapy, I'm mobile a lot of times. So I'll take my table to people's houses and they'll lay on my table and they'll start off feeling like, I can't do this, I can't do that. But after a couple sessions, they'll get to see I'm opening up in certain areas, right? My leg can go back a little further than it could before. I'm sleeping better because of these things. And so I would say, don't let fear stop you. Also, there are studies that show that our body, our cells listen to us when we speak. So mind the words that we use when we talk about ourselves. Mind your thoughts when you talk about yourself. And just say, you would like to be more flexible. I would like to no longer be in pain, right? I would like to live pain-free. But don't let it stop you from trying a different modality of peace and healing that might be helpful to you. Please don't let it stop you.
The power of the mind, right? Because it does translate. And for someone who's saying, I have in the past felt really overwhelmed and I want to make a new change. I want to reset my mind. What are some a simple 2-minute practice that they can start today if they don't have a yoga studio to go to?
So I want to start with just saying that the beautiful thing about yoga, and if it helps to take the name out of it because they're, just negative connotation, but the beautiful thing about the practice is it is the body, mind, and the spirit together, right? And it can be done anywhere. It can be done at work. It can be done in line at a store. You could be doing something as simple as a tree pose. And no one would even know. Angela Davis learned about yoga in prison. And one of the things she said she loved about it is the fact that the guards couldn't take it from her because they didn't know she was doing it. But it was so freeing for her. So I would say, maybe just starting with your breath. And I love the simple fact of just reminding people that our breath is our life source. So because the breath is yoga. The yoga is, the poses are like all a way of getting us connected to the breath, which is all a way of getting us connected to ourselves and our mind. So the poses are like that compared to the breath work and the meditation. So I would say start with your breath. Put your hands on your heart, maybe on your belly. If you want to close your eyes, if you feel safe, just take a big breath in and let it out. And just doing that a few times and just noticing how you feel, noticing if your shoulders soften, things like that, right? And then once you've got the breath, maybe start with some cat-cows. If you're in a chair, you can just round out the back, lift the chest, lift your chin, lift your shoulders. So there's a lot of different small moves you can start with that'll help increasing the flexibility of the spine, the shoulders, opening up the low back. Don't let what you see, the fancy things on social media and pictures and stuff fool you. All that's not necessarily yoga. it can be hard for some people to even sit Indian style because your hips are tight, right?
Right.
And just being able to get to a point where you're able to do that, that's a really big deal. So just small progressions.
You know, you mentioned we need to be doing these things, especially when we're stressed out, right? So for our audience viewers who have stressful jobs and they're sitting at a desk all day, because you're a lawyer by day, correct?
Yeah.
So when you're stressed out at work, how do you practice some of these techniques? And is this something that you just say, hey, at work is at work. When you come home, this is what you can do?
No. So I try to show up as myself everywhere I go. You can't show all of yourself, right? But I try to, this life is just easier, right? And so this is a part of me. You know, I have people tease me sometimes because they'll say, you move so slow, right? Sometimes I'm intentionally slowing down because I'm rushing for what? Like, we're rushing for what? Like, if I'm running late, then okay, maybe, but like, why does everything have to move so quick? And why does everything have to be so loud? So sometimes just me setting that boundary is a way of me being able to practice my yoga. Again, it's not always about the physical movement. Sometimes I'll put my hands on my heart and I'll start my breathing and my breath work, especially after a stressful meeting or stressful exchange. Yeah.
You know, well, thank you, Danny, for reminding us that rest is not a luxury, it's a necessity. And you mentioned earlier that you have a mobile clinic or a mobile yoga.
Yeah.
How can they find that? How can they get in touch with you if they're saying, hey, I do want to reclaim my life. And one way I want to reclaim it is by doing this somatic work and recapturing my sanity.
Yeah. So it's DannyLynn_yogi. It's an Instagram page.
Thank you. Danny Lynn _yogi.
Yes, ma'am.
Be following you. Thank you so much. And still to come, my prescription of the week.
A decade of love, joy, and power. Black Voters Matter is 10 years old, and we are just getting started. This is love with a purpose. This is Black joy in motion. This is unstoppable power. Across campuses, neighborhoods, and back roads, let's go! We show up not just to vote, but to be seen, to be heard, to belong. We ride together, we organize together. We remind each other that our voices matter, because they always have. Black Voters Matter is about more than ballots. It's about housing and healthcare, clean water and living wages, education, reproductive freedom, and dignity. It's about turning pain into action, turning belief into movement, turning community into power. We don't wait to be invited. We bring the energy. We bring the love. We bring the people. Because when Black communities come together, we don't just survive, we thrive. This is how change happens. This is how history moves. We organize, we build, we win.
Your morning coffee might be protecting your brain. Now, quick question. How many of us start the day with coffee or tea and don't even think twice about it? Well, it turns out that daily habit might be doing more for you than keeping you awake. A major study published in JAMA followed over 130,000 people for decades, looking at coffee and tea consumption and the risk of developing dementia later in life. And the findings are worth paying attention to, especially for our community. People who regularly drank caffeinated coffee had a lower risk of developing dementia. Tea drinkers showed similar benefits, but here's what stood out. Decaf didn't have the same effect, pointing to caffeine and other natural compounds possibly playing a role in brain protection. And the sweet spot wasn't that extreme, only about 2 to 3 cups of coffee a day or 1 to 2 cups of tea. It was that consistency mattered more than quantity. Now, why does this matter for us? Well, Black adults are more likely to develop conditions like high blood pressure and diabetes earlier in life. And both of those conditions increase dementia risk. Chronic stress, lack of sleep, and limited access to preventative care all stack the odds against long-term brain health. So when research shows that everyday habits might support cognitive health over time, that's not trivia, that's actually strategy. Now, this study doesn't say coffee is a cure, but it reinforces something really powerful, that small daily choices compound. What you do most days matter more than what you do once in a while. So with your morning cup of coffee, pair it with meditation, pair it with sleep, pair it with movement, pair it with managing stress and staying connected, because protecting your brain isn't something you start later in life. It's something you build one habit at a time. And sometimes it starts with what's already in your mug. And that, my friend, is my prescription of the week. Thank you all for watching, and see you next week on Second Opinion.